a nonpartisan grassroots civic organization that encourages informed and active participation in government, works to increase understanding of major public policy issues, and influences public policy through education and advocacy. The League does not endorse individual political candidates or political parties. Membership in the League is open to people 16 years and older of all gender identities. Today's meeting topic is suicide prevention. And this time I'm going to turn it over to Chris Junker to introduce Hunter.
All right. Well, I believe this all got started because September is Suicide Prevention Month. And there was an article in the paper, or editorial in the paper, that was written by Michelle Beaver, the director of South Heartland District Health Department, that talked about the QPR training that's available. And QPR, I always have to write it down, question, persuade, and refer. So it's a suicide prevention training that's available through Region 3, which you're going to learn more about in a little bit. But I kind of took the liberty to say, you know what, there's so many there's different levels of suicide. You know, there's the prevention side, but there's also the side that comes when suicide's not prevented. And I think Hunter's going to talk about that. That's called the postvention. There's also a loss team that I think you'll probably talk about that as well. So there's lots of different things that can help folks get through suicide. And you know, I think suicide touches a lot of us, and we don't know how many it touches. And I lost a dear friend in 2005. Ken Gallagher, that dirty rat. I'm just going to throw it out there. And so I did the QPR training. I went through so many things to help me get through that. And I'm so grateful for Region 3 and the services that they provide over there to help us through that. So I'm guessing Hunter will talk about Region 3 a little bit, Ada Carney, Region 3 Behavioral Services. So with that, I'm going to turn it, and Hunter just said, this is Hunter Ludwig, by the way, and his whole entire job is focused on suicide issues. So we're glad to have you here. Thank you so much.
Thanks for having me here. Like you said, my name is Hunter Ludwig. I am the Suicide Prevention Coordinator at Region 3 Behavioral Health. If you're not familiar with behavioral health services, Nebraska is split into 6 different regions. The whole center part is Region 3. I cover Buffalo County all the way to York. I have all the way down to the Kansas border, and I get pretty close to the South Dakota border. So I cover a pretty large region. The whole region does. And all of the things we do are related to behavioral health. Suicide has fallen underneath that umbrella here in the last few years. And I've been here full time for a little over 2 years now, doing suicide prevention trainings. And before we get started, I do want to say I know suicide is a difficult topic and has probably affected people in this room. If you need to step out today for any reason, please feel free to do so. I just ask that afterwards you come talk to me so I can make sure you have everything you need to be okay. Sound good? Perfect. All right, so I just want to go through and do a quick overview, and this slide looks really scary, don't worry. I'll read it to you real fast. Before we talk about suicide, we need to talk about mental health, right? 90% of people that die by suicide have a diagnosed mental health issue, or, the issues that we're looking at, the illnesses, depression, bipolar disorder, schizophrenia, those sort of things which seem pretty normal. Everyone would kind of think of, right? But it does fall into more unknown ones. ADHD is one that also increases risk of suicide, right? So any mental health diagnosis can lead to an increased risk. And throughout today, I'm going to say things that increase risk. The more we have, the more we see, it's just more common it is, more likely it is someone may make an attempt, okay? 10% of suicides are associated with a psychotic disorder such as schizophrenia. Schizophrenia is kind of our highest at-risk group that we have. 90% of people who die by suicide, like I said, have a mental health disorder or a substance abuse disorder or both. Okay, both these things are very detrimental for people trying to stay alive. More than 50% of suicides are associated with a major depressive episode. Okay, 50%. And the reason depression is so heavily focused on is because of that big 50% number, right? Even though schizophrenia is our highest at-risk group, more people are dying from depression. And so that's why it's so heavily pushed to try to get help for those things right now. Only half of Americans that are experiencing an episode of major depression receive treatment. right? So a lot of people even aren't going out and getting the help they need right now. And then I do have some stats specifically more for childhood and adolescent rates. Depression is the leading cause of childhood adolescent suicides. 57% of near suicides in the population have major depression, okay? Some scary stats here, 1 in every 33 young children and 1 in 8 teens now suffer from depression. And what we're kind of seeing now is about 1 in 9 teens make an attempt. Rate of major depression is 2 to 3 times higher in adolescent females than it is in males. We'll talk about some gender disparities here in a little bit. 4 out of 5 runaway youth suffer from depression, and a lot of times it's even misdiagnosed, right? It could be considered a behavioral or a social or a learning problem. Because depression does manifest itself in different ways for different people. Okay? We talked a little bit about the gender here. So here's a graph kind of based off of our age ranges here. Males are this darker blue, females on the left are that lighter blue, okay? We see a pretty large disparity towards the male population. And what's kind of scary is that 75 plus range is about 40 deaths per every 100,000, right? And there's multitude of reasons for this. I mean, there's that stigma behind, I'm a man, I have to be the strong caregiver of the family. And when they're starting to not be able to care for themselves as much, that's pretty stressful for a lot of people. This is also more around the time of terminal diseases start getting diagnosed, or even the loss of a spouse. The loss of a spouse can be it's a very emotional time, right? That person they've relied on for a lot of their life is no longer there for them to help rely on and talk to, those sort of things. Our biggest rate group for females then is that 45 to 64. This is the fastest growing group on both sides, is that 45 to 64-year-old range, okay? I do want to talk a little bit about what risk factors look like for people that are suicidal as well. Changes in behavior are kind of the easiest ones or the most common signs that we see. Negative mood and emotional state. Now, I woke up this morning and I stubbed my toe so hard I cracked it, my toenail. So you can imagine I was probably a little grumpy this morning. That does not mean my risk for suicide increases though, right? We're looking for things that are more out of the ordinary, kind of more unexplained, okay? Another really big one is that loss of interest or usual activities. The things people have loved to do and they suddenly don't want to do them anymore, or the people they've always enjoyed being around, suddenly not wanting to be around these people anymore, right? Are good warning signs. Hopelessness is what we kind of say is the leading cause of suicide. People that have hope usually don't make an attempt. It's when they feel like there is no hope, nothing else they can do, that the attempts usually start to come in. That withdrawing from friends, families, social activities, sleep problems, and unfortunately we can't say one way or the other. It is one that manifests. Some people sleep all of the time when they're feeling suicidal or depressed, and some don't sleep at all, more of those manic type episodes. Major life changes can increase people's risk as well. Illness, a loss of someone close, or relationship difficulties. Death, especially by suicide, is pretty difficult. There is something called the contagion effect for the suicide. Things like suicide and divorce seem to be almost contagious, right? Once one happens in an area, it's more likely that others will happen in the area, that sort of thing. And so there's different protocols after a suicide death we'll hop into later called postvention that you're supposed to follow after a death by suicide. Legal troubles, job loss, loss of status, going to prison, those sort of things are large stressors in people's lives as well. Changes in residential, marital status, or parental status are all other ones that can increase risk. And changes in substance use. And this can be relapse, and relapse is an especially difficult time for people. Okay. And then plus having access to lethal means. Lethal means is what someone would use to make a suicide attempt, right? And I have a training specifically all about that too. We'll dive deeper into my trainings here in a little bit. Then there are the verbal and behavioral signs that we see. If someone said, I can't take this anymore, nobody cares what happens to me, people would be better off if I wasn't around, nothing's gonna change, I'm gonna feel like this forever, or I wish I were already dead. These are all very concerning things. If you heard them, you would most likely know this person needs to get help, okay? Unfortunately, this isn't how most people communicate, right? Usually it's behavioral signs, okay? This is the most common way people would communicate an intent. Just appearing agitated, How do you know then if that person's suicidal? There's many different trainings, many different things to look at. The more warning signs we see, the higher the risk, okay? Seem less social, more withdrawn, and this is gonna be more for people you know already. Having difficulty sleeping, trying to obtain means, like stockpiling medications, and exhibiting changes in your usual behavior, right? And that's very difficult and kind of a scary thing to hear. If people act differently, we need to worry about them, okay? That just means we need to check up on them more often, right? If we're seeing some signs that seem strange to us and our friends or family. Here's some Nebraska facts. This is from 2018. But in Nebraska, we had someone die by suicide every 36 hours. This number has gone up since this. 4 times as many people died by suicide in Nebraska than by homicide. 4 times more. Okay. In 2018, we had 246 suicide deaths. That was 13.05 per 100,000 in Nebraska. We're currently sitting at 14.4 per 100,000. So the number has gone up. There have been more suicides as of late. Our state rank is 37th, which is actually kind of surprising. The more Midwest, the less big cities you have, the higher the chance the lower the chance someone is going to be suicidal if they're around those big cities, right? The disparity we see though with Nebraska is 2/3 of our population live in 1/3 of our state, Lincoln and Omaha, okay? So don't let this fool you. The rates out here are a lot higher than over there. We're closer to the 17 or 20%, depending on what county you're in this area, per 100,000 than in the Omaha and Lincoln area, which are lower, like the 12, 14%. Okay? So this number is a little skewed because of Lincoln and Omaha and most of our population living there. But it's going to be things like just lack of access to healthcare or mental health care. The farther you are from it, the less likely you are to go to it. And there's a lot more stigma, right? I grew up farming, and talking about our emotions wasn't something we really did a whole lot, right? There's stigma behind it, okay? And so my goal is to get out there, reduce that stigma, and talk about this more often, okay? Here is a chart. If you can't read it, don't worry, I'll explain it to you. These blue squares, these are deaths by suicide. These are the 10 leading causes of death by age range. Starting at age 10 is when suicide is the second leading cause of death, okay? The only thing beating out until the age of 34 is unintentional injuries. That's anything from a car accident, falling off ladders, those sort of things, okay? So I do have programs, specifically suicide related, that start at age 10. And I've recently been lucky enough, I've been able to get an emotional regulation class for kindergarten through 4th graders, just to help curb that before it ever becomes a problem, which I'll dive into here later too. One important thing I do want to point out, so age range 25 to 34, 8,059, 35 to 44, 7,500, 45 to 54, 8,012, 55 to 64, 8,200. The amount of people dying in each group isn't going down, right? There's still about around that 8,000 mark people die in each age group. And just because they're not on this anymore just means other things have come into play, right? Things like those malignant neoplasms, cancers have started coming in, heart disease, liver disease. Other things have started to come in, but suicide is still prevalent in every age group. Oops, I already showed you that one, but there it is again for you. Okay. And then I do want to take a quick moment to talk about language, okay? So part of my job is reducing stigma behind talking about suicide, and word choice can matter when we talk about this sort of thing, okay? You may have noticed I have been saying died by suicide today. That is because we try to stay away from saying committed suicide, okay? And there's several reasonings for that. What else can you commit? Crime. Up until the 80s, a suicide attempt is something you could go to jail for. It was a crime, okay? And then there's also the thought process of being committed to an asylum, right? That's not what we do anymore. There are so many ways to help people now, and it's not just locking them up, okay? And so we're trying to move away from those phrases, and it might sound silly that we're trying to put a more positive spin when we talk about suicide, but this is important because it gets more people to talk about it, right? So we do want to say things like they took their own life, they died by their own hand, died as a result of self-inflicted injury, or died by suicide. We're trying to put this on a level playing field as all other forms of death, right? They didn't commit cancer, they died by cancer. They died by suicide. Let's make it easier to talk about, so we do this language change, right? We also want to stay away from things like a successful suicide, because suicide isn't something you succeed at. That's not something we want people to think of as succeeding at, right? Same with completed suicide. It's not a goal, it's not an objective. It's not something we want people to be doing, so we do want to say they made a suicide attempt, they died by suicide, those sort of things. And then one down here at the bottom, chose to kill himself, okay? This is a controversial one, and this is why I put it in the don't recommend category, okay? Some people believe that suicide is a choice. Other people believe they are not in the mental capacity to make their own decisions currently, and so it was not their own choice, okay? And so just to help protect you, if you ever do talk to someone, try not to say chose to kill themselves, just in case they are on the other side of that argument. And so in safe messaging, we want to make sure people know about 988. Does everyone here know what 988 is? Yep. What's really nice is here within the past couple of years, it is call or text now. They also have a chat line for computers. It's in English, Spanish, and they added sign language support. And they're currently working with police officers in several of the regions to work on warm handoffs. So if you call the police and you say you're suicidal, they're now going to get you connected to mental health care instead of just an EPC, which is those emergency protective, oh, I forget what the C stands for. But instead of just custody, thank you. Instead of just taking them, putting them somewhere when that might not be what they need in that moment, right? They are working to get people connected and get more help when they need it. Making sure we're talking about warning signs. I brought a bunch of goodies today and also a bunch of pamphlets. I'll have warning signs for you that you can take if you wish. If you ever need more, let me know. All of my stuff is completely free, including my trainings, and I travel to you. Early help for mental health and substance use problems. That's something you may have noticed bigger pushes of lately. Especially like with my program, I talked about working with kindergartners before suicide ever becomes an issue. And then support some local efforts to prevent suicide. Over in Kearney, we do 2 suicide prevention walks a year. Tomorrow night is the Moxie Gala, which is raising money for suicide prevention in Kearney. Try to figure out what your local, what you're doing locally to prevent suicides, and see if you can be a part of those as well. Some things we do want to avoid. We don't want to have detailed descriptions of a suicide incident, okay? We never want to talk about where something happened or what was used in the suicide, okay? Just to help prevent some of those copycat suicides. Around the time of Robin Williams' death, some places were using safe messaging and some weren't, and you could kind of track back and forth the areas that weren't using safe messaging, where they described where and what was used. There was more copycat suicides. Those that didn't explain that, instead were promoting mental health resources, saw low or no increase in suicides. So communication does matter. One of the more difficult ones is making sure that we don't paint the person as just a celebrity. We do want to highlight that they were struggling, right? So that people don't feel like, or people that can relate to that can then go get help, right? I'm not saying talk bad about them, but making sure we let them know, that other people know they were struggling with their mental health during this time. It's okay to talk about that. We also want to be careful oversimplifying causes. Suicide is extremely complex, and it's never down to just one reason why someone dies by suicide, right? Saying things like they died because of bullying are really more harmful than they are beneficial, okay? Because it is more complex than that. We also want to be careful about overstating the frequency of suicide. We don't want to say this is a very common occurrence. If we say things like this, people might think, well, what's the point of me getting help if it's just going to happen anyways, right? So we don't want to overstate how frequent it is. And then making sure we're using the correct terminology, not saying things like they failed at a suicide attempt or they had a successful or they committed suicide. Okay. So this is the part where I'll kind of dive into the different programs that I do over at the region. Like I said, all these are free. I will travel. Just let me know if you ever need them. So first up, SOS, Signs of Suicide. This is one specifically designed for schools. I've gotten permission to start this in 5th grade, and it goes all the way to 8th grade for one, and then the other one is freshmen through seniors. There's 2 different versions. one designed for the younger population, one for the really older population. This is an evidence-based model. We take kids through different scenarios and warning signs to show them what to be on the lookout for in their friends, right? A lot of people that die by suicide, especially in the youth population, their friends kind of knew about it but just didn't know what to do, right? So we've started paying for, and I come and do the training for SOS. It's a 45-minute quick presentation. It's supposed to be done in one class period type thing. To teach them what to do, how to identify those warning signs of depression and suicide in themselves and their peers, while providing materials that support school, professionals, parents, and communities. And what's nice about this is it does have things for the parents, right? It's not a blindsided thing. There's letters that go home. There's even a parent class that they can come to and see what's going to be taught beforehand, and materials for the community. Then QPR was one that we talked about. That does stand for question, persuade, refer. And it's very intentional that it sounds like CPR. So QPR's intention is to keep someone alive until we can get them the help they need, right? And it'll go through what the warning signs are, how to ask someone if they're suicidal, how to persuade them to stay alive, and then who do we refer them to? How do we get them connected to help? Suicide postvention is one that is usually done after a suicide. What's nice is I can go into businesses and organizations before a suicide ever happens, and we go through it, and it actually teaches about how to write policies for suicide, whether it be a staff, a client, or just a community member. Unfortunately, most of the time I use this after a suicide happens. I can go into schools, businesses, organizations after a suicide, and I help walk them through what correct procedures are, how to talk to the media, that sort of thing. But it goes about how to communicate through safe messaging to all staff, students, families, those sort of things, and identifying community resources to promote healing, while we also do work on the overarching goal of preventing suicides through postvention. AMSR is assessing and managing suicidality risk. This is one specifically designed for counselors, if there's any counselors in the area. It walks them through how to take someone who is at risk for suicide, developing a plan and working with them to get them back to that baseline level, which is going to be pretty similar to the CAMS model. This is one that is completely online though. It is a pretty intensive course, but it does similar things on how to treat people that are suffering from serious thoughts of self-harm and taking them back to their baseline as well. And that one is specifically for clinicians. And then my favorite one, Gizmo's Possum Guide to Mental Health. This is our newest one we started implementing with that preschool through 4th grade. And it follows the story of a therapy dog named Gizmo. And in the story, he goes through and he figures out what to do whenever he's mad, sad, or worried. And at the end, they actually fill out a little plan, each kid that goes through this, on what to do if they're ever mad, sad, or worried. And it's meant to go up on their fridge to help teach them this emotional regulation and control, right? To hopefully, so if they ever do start getting depression, those sort of things, they're better equipped on how to deal with those emotions. Okay. And that was just kind of a quick overview of everything. I did want to leave time for questions because I'm sure there's going to be plenty of questions. So if you would like to contact me, here's my information. Like I said, I am free. I will travel. Let me know what you need. They had to give me a second office just to store all the materials I have. Okay. Oh, speaking of that, I did bring materials for people today. While I get this out, are there any questions? Yes?
That age group, 55 to 65, that's the fastest growing for men and women, what do they attribute that to? Is that just midlife crisis time, or?
Like suicide, it's very complex,
okay.
Right? We don't directly know all of the causes. There's
sure.
many different things. Financial stress is a large one, but that's also the more common divorce range, those sort of things. So it's a pretty complex issue, just like suicide
okay.
itself.
That surprised me.
Yeah, and it usually does, yes.
Our state legislature cut 15 million, if I remember correctly, from the mental health budget.
Mm-hmm.
How does that affect you and like your salary, or does that affect outreach? I mean, obviously that affects somebody.
Yes.
We have a serious problem here, and our Nebraska legislature is not realizing that.
Gotcha. Yep. So the budget cuts, some of it was for the region. And what that meant was a scale back on a lot of our funding that we give out to other programs, other organizations to help. Just cutting back on all those, kind of like we were cutting back as well. So we didn't erase any of our programs, we just cut back on the amount that we could spend for each program.
But that obviously affects how you reach people.
A little bit, yes.
A little bit.
Okay.
Yes.
Can you talk about, I know that the schools do some sort of suicide prevention training every year with their teachers. Can you talk about that a little bit?
Yep, so that was a law passed that all school, I believe all school workers in general, not just teachers, had to be trained in a suicide prevention model. That QPR that we went through is one of those models that you can use. I've done for schools, and it's free. A lot of places you do have to pay to go through whatever model they use. So just something to be aware of there, if you know anyone at a school that would like that sort of thing. Yes?
Do you know what the rates are, I guess, for immigrants and non-English speaking people? And then does your organization help with outreach for non-English speakers?
We do. So I have an entire shelf dedicated to just Spanish materials in my office. That is our second biggest group. Caucasian is the largest group though for suicide, and that is where most of the focus tends to shift. But we do outreach to other ones as well. One of the things I do, I actually call courthouses and I ask, what translators are you currently waiting for to help with cases, just to help me know what's in the area. And through that I've started gathering materials that, for Somali, Mandarin, other languages that I wasn't even aware of that were in some of our communities. So yes, we do outreach to those, and we have translation services at the region as well. Yes?
How much work have you done in Hastings, in our public school system?
I have not, unfortunately. This is something I have to be invited in to do. I haven't had a good in at Hastings yet. If anyone has a connection at Hastings, please let me know, or let them know what I do. I would love and be happy to come and do more here. Specifically, I do want to do a lot more in Hastings. Of my big cities, Hastings is the one I get the least calls for. So if you would like any trainings for any organizations or know anyone that might, please send them my way. Okay? I do want to get into Hastings a little bit more.
We have some new board members on the school board, so maybe we can talk to them.
Sure. Yeah.
Well,
And the old ones too.
Yeah, I just want to go back, because I know like the QPR training, so it used to be, I helped set this up, so
Yeah.
there was 4 different trainings that were rotated that the teachers had to take annually, and one of them was QPR, so I don't know where they're getting that training. I know Mary Lanning has some QPR trainers there, so maybe that's where they're getting that at.
Are they getting it?
Some of the,
So are they getting it? 'Cause
Well, it's required every
it's
year. that they-
required.
not specifically QPR,
Right.
but a
Big
suicide
suicide
prevention
prevention.
training,
So.
but
and-
most do QPR.
Yeah, one of them is, so every 4 years they get QPR, and then it's on a rotating thing. But I know there's an online one that teachers get 1 year, and then I don't remember what the other 2 were. But again, every year
So there is something every year.
there is for the educators, or the folks within the school systems.
Yes.
And I will I mean, I've taken that over and over and over again for the school system every year. And I will tell you that if you aren't listening or aren't paying attention, you have to go back, because you have to answer the questions as you go. And if you don't get them right, you have to go back and go over that section. So you learn really quickly that you pay attention and you follow all directions and you take down notes, because you're gonna have to answer these questions as you go. And if they are not correct, you're gonna have to go back and do that section again. So something that they tell you is gonna take an hour of your time could quickly turn into a longer amount, especially when you only have like 5 minutes that you really can devote to that, and they're telling you you have to take an hour, and then it turns into a longer time. So, I mean, when they get done, and they have to do it over every year, over and over again. So, I mean, training for the school personnel is not, I don't think, the issue.
Mhm.
It's getting the information to the students. I mean,
Yeah.
we're taught to recognize and to look for, but if you're referring a student and there's the money's been cut and we don't have somebody to help them, or we don't have anybody to come in, or we don't have anybody to help the family, then there's wherein lies the problem.
Fair, very fair argument there. I did realize something. I think the reason I had a double up slide was because one of those was supposed to be for another training I do called CALM, Counseling Access on Lethal Means. There's 2 different versions I'm trained in. I'm currently working on becoming trained in a 3rd special version. But the main version in gatekeeper training for anyone is what to do with guns and medications and the things someone is thinking about making an attempt with in the house, right? And it is nice because it does not take an anti-gun or anti-medication approach. Just because if you go and tell a gun owner, hey, you have to get rid of your guns, they're gonna stop listening to you right away, right? And so it teaches people how to keep them safe in their homes or promotes temporary storage. And that's one of my big projects I'm currently working on. I'm working with UNL's Public Policy Center right now. And our goal is we're about to go live with it here soon, so keep your ears out. That all gun stores, we're going to promote and try to get them to offer safe temporary storage for firearms for those that are in need of it, right? So if anyone is going through a crisis or a family member is going through a crisis, they do have safe places to take them. That's part of the CALM model. The other version I have for CALM is CALM counselors. It's specifically me going and teaching counselors what to do so that they can instruct people how the safe way to handle firearms and medications are. And then the third one I'm working on is called CALM Safe. This is one I have to go become a range safety officer before I can become a trainer in it. And I actually go through and I teach people that don't know about firearms the different parts of firearms so they can learn how to safely store them or put gun locks on them, those sort of things. And that'll hopefully be the newest one I get here soon.
You didn't mention that, so is guns, is that the largest death by suicide?
So this is something we have to be careful when talking about because we are now talking about how someone dies by suicide.
Correct.
I will let you know that in Nebraska, about 55% of all deaths by suicide are firearm. And then before more questions real quick, I just want to let you know what I have up here. I brought some packs. These are little just pamphlet cards. These are suicide warning signs in adults. Suicide warning signs for youth. Something at the region we do is we do promote safe storage. So we do provide gun locks. This is a lock box that we have. It's a lot more sturdy than you'd imagine. We have ammo lock boxes, that sort of thing. Then we also have pill boxes that have the 988 number on the top of them. So that every day someone sees these when they're getting medication, if that's a worry. Another project I've been working on, I'm hoping to get here in Hastings soon as I get approved for the overtime. Going to all the bars and coffee shops and distributing coasters with a 988 number on them. Just because alcohol is a big factor if someone is already depressed. And then coffee shops are common meeting places for people that are in AA. People that may already be struggling, and so they are more aware of these numbers as well. Then I have magnets and tear-off pamphlets. These are non-911 emergency numbers. So we do have South Central Behavioral Services on here. We have Mary Lanning, National Suicide Hotline, Abuse Neglect Hotline, Nebraska Family Helpline. Good numbers to know, more for the mental and behavioral health side of things. Something specific I think some of you might here enjoy. I really do. We got rubber bookmarks, but it has grippies on the back so it won't fall out of the book. Yeah. Yeah.
1, 2, 3, 4.
Perfect. Like I said, if you ever need more, let me know.
He's got a room full.
I do. I have 2 rooms full, basically. Just general 988 cards. These are good to hand out to people that we might be worried about or leave laying in an area for people to grab as needed. And then another thing I brought for you today, I did run out of pens. I have more on order, but I brought mechanical pencils if anyone likes mechanical pencils. Now, back to the question. Sorry, I just want to make sure I got that out. Yes?
Are you maybe seeing an increase in the use of technology in the rural areas to get mental health services?
We are. It was kind of catapulted ahead during COVID, actually, which is good and bad. Because after COVID, we did see a large increase in suicides and suicidology. But because of not being able to go to offices and that sort of thing, telehealth has become pretty big. And a lot of places will offer telehealth for people that are far away or don't have access, those sort of things. So yeah, we've seen a big increase. Even 988, they track how many calls they get, and as the numbers been getting out there more, I'm sure you've heard there's been radio advertisements, billboards, that sort of thing. As that's gotten out there, we've seen an increase in people using that. And what's kind of exciting to see is the numbers starting to plateau a little bit for suicides, which is usually a good indicator that things are going to start going down. In a recent survey, like nationwide, I believe they said overall the feeling of suicidality is down from the past years. So hopefully good signs. Any other questions?
Is there a nationally recognized day or month that's National Suicide Prevention?
September.
September,
Yep.
okay.
Yep. September is, and that was my busiest month I've ever
I
had.
bet.
Oh wow, yeah. I was doing 2-3 trainings a day in different cities sometimes, but that's a good thing. I like to be busy. That means I'm getting the word out there more. So
But not in Hastings.
a little bit. I've been here a couple times over at the bridge specifically. They've been reaching out a lot, and I've distributed some resources to a few local areas too. So.
And Hunter did the calm training for us at the health department a while back. It wasn't, I don't think it was in September, but it was a while back.
No, yeah, it was before that even. I think
Yeah.
it was in the summer. I'm pretty sure.
Yeah, so that was interesting.
Yeah.
So as a teacher, I was always concerned with like the teen level and college level, but what I'm seeing with the statistics, senior citizens
Yes.
have a high level of death by suicide. So what specifically do we do, or what specifically do you do to, because they have, I don't know, do they have, I mean, they have different issues because a lot of them are health,
Mm-hmm.
financial, loss, grieving, I don't know, help me out on this. What's being done for that, or what do you do?
So I have been in a lot of nursing homes lately, just as a good starting point. I go to a lot of mental health fairs as well that do tend to be the older age range. Basically, I go wherever the people are, distribute materials, like you see here today. I bring this sort of thing everywhere too. Then there are specific advertisements even geared towards that older population, just because it is the higher risk group.
Do you ever get invited into banks to talk to bankers about suicide?
I haven't yet, but I would love to.
Yeah, that would be.
Yeah, so
Hey,
yeah.
I'm thinking of ag bankers, what?
Yeah, so I'm also, I have a lot of projects. I love to work on projects. Another one I'm working on is something called Neighbor for Neighbor, getting it restarted in Nebraska. And it's one specifically for that farmer agricultural group
Yeah,
on how to look out for your neighbors,
right.
right? Because they're more likely to see it than anyone else would. So that's another big goal of mine, and is currently something that there is grant money out for, that we're currently using the money for that 24 to 64 year old male population that are more rural. Yeah.
I was within the last few weeks in rural western Nebraska. I had a church call me, a farmer or rancher struggling with mental health. Do you work with churches much for outreach?
I do. Some of our funding, the way it's broken up, I have some set aside specifically for faith-based organizations. So I buy like lock boxes so that those available. I make sure to do trainings, reaching out, those sort of things. And one of our new big goals that we're trying to get someone to come in that can do the trainings in Spanish as well. Because Spanish churches have been kind of my biggest group that have been reaching out to me that I really haven't had the ability to go and do the trainings for.
Do you remember the crisis hotline of a number of years ago, that rural help? It was a rural.
The rural,
Yeah.
Nebraska Rural Helpline?
Yeah, well.
Or Nebraska Family Helpline?
No,
Or
no, there was a crisis help.
the one through
Hotline.
Boys Town?
No, you
University of Nebraska
I-
did,
yeah,
wasn't
somebody
it
had
through
that, but it was-
Extension University of Nebraska?
Oh, the extension office?
Yeah, through Extension University of
Oh, okay.
Nebraska did a lot of stress for ag workers.
Right,
That's
ag workers,
yeah.
UNMC.
Was that UNMC?
Dr. Ramos.
Because when it went away, it was no longer funded. I wondered, what I'm trying to think about is, has our technology that you were talking about, has that replaced the picking up the phone?
So people
So
still
you
pick
got
up the
the
phone?
988, but
Yes.
But is that, maybe it's replacing that, so maybe that's a good thing.
Yeah, so when you call into 988, it's gonna give you a list of options, right? But besides those options and whatever number you click on, like one is the veteran line, that sort of thing.
Okay.
What is nice though, it's gonna go based off your area code. So those 308s, the 402s, you're gonna get connected to someone in Nebraska or close to Nebraska. Unless the lines are full, then they'll bump you to the next closest one. And they do this because a rancher in Nebraska and a guy that lives in New York City doing mental health, they're not gonna understand each other's problems, right? They're not gonna have the same level of understanding, right? So they get those more local people trained specifically to deal with more of the area they're in, to hopefully help them, those farmers and ranchers that do end up reaching out. Good question.
Do you know if they had reached out on any of the helplines or anything when you were out there, Joe?
I'm not for sure.
Oh, yeah. The other thing that you just brought up a little bit is the people who are coming back from service. Are we still in the veterans? Are we seeing, I know that South Heartland had, do you still have that program? You don't have that veterans program anymore?
Not as strong, our staff person left, and so.
Oh, that was,
that
because that
happens.
was,
Yeah.
I worry about effectiveness. Do you have statistics on, has that gone down at all with the?
The suicide rate for veterans specifically has not gone down, no. But, flip side, more is being done right now. SAMHSA, which is kind of a big mental health component in the United States, has started and is funding in Nebraska specifically right now 2 different big programs. One is the Governor's Challenge, which is to reduce suicides in specifically military families. And then the Suicide Mortality Review is going to be groups put together to review suicides, what were the causes, and then work on getting the fixes for those causes.
Is that under the health service?
That's not through me, that's through the state.
To the state.
Yeah, the state, that's something the state, it is things that I am on the calls for, just to help be that suicide prevention support, that kind of thing.
But how did the cuts of the budget affect that, you think?
This isn't state funded, it is a national program funding it, called SAMHSA. So they did not suffer from budget cuts there.
And just one of the things that I've been working on at the health department, we had some funding to look at adolescent mental health services. And so one of the things I did was do a survey just to kind of analyze what the culture felt like here, where are the gaps. And so, of course, you can imagine there's not enough providers. So we were actually fortunate to work with an organization that supported us, and we were looking at cell phone use and social media use and how that is hurting the mental health. You know, there's still no direct, correct me if I'm wrong, I mean, you know, bullying increases suicide, but they've never really targeted it that way. But cell phone use and social media certainly don't help that. So I worked with some folks out of Knuckles County to do some presentation for the schools. And it was actually Lawrence Nelson on smart cell phone use. And then we were gonna do a QPR training down there, so I was talking to Hunter about that. Well, then there was a suicide in that area, so we backed up because, so we've got that on our radar, but we're still just trying to do some things out there to kind of just help adolescents at least be more aware of what they're feeling and how to get through that, because we have to work around the lack of providers.
Well, prevention is still the best medicine, if you could do it.
We do need to be careful with after a suicide though, coming in with preventions. If I came in and did QPR to a group that had just lost someone close to them, I'm now standing up here saying, this is what you didn't see, this is what you did wrong, those sort of things. So there is an amount of time frame you want to have, but postvention very quickly becomes prevention, and it kind of flows itself into the whole thing.
Well, I was referring more to the uptick in mental health.
Oh, yes, sorry, my
That's what I was
apologies.
kind of thinking, because I wasn't thinking of that. No, I don't, no, I agree with that.
Yeah.
Wow. It's really tough.
And this was very fast and furious through a lot of the stuff I do. If you do have any questions, please reach out. Anything else?
Did you bring some of your cards? Maybe
That was the one thing I forgot.
Okay. Maybe you can get
They
them
are-
pressed and you can get
They are
them.
sitting on my desk right next to my computer that is right there now.
Well, that's because you stubbed your toe.
Probably, yeah, all because of the stub toe.
You're all mentally out. So did I.
Yeah, exactly.
I told you not to put me in the front row.
You keep it more lively. I like it.
I warned you, Andrew, didn't I?
No, it's great. It's great.
I'm curious what your background is. What did you
So
study and major in? And
I majored in elementary education, actually. I was a teacher for a few years.
Judy, did you see that? Did you?
I wondered.
Yep, so I taught for a few years. My last year I was doing middle school special ed, that sort of thing. And my wife and I ended up moving. And after the move, there wasn't, I couldn't sign up for any schools right now because they weren't hiring at the current moment. But this popped up, and suicide is something that's near and dear to my heart, right? I lost a very close friend when I was in high school. It was a very difficult time for me, but I kind of made a promise to myself to help where I could. So I took this and I never looked back. This is something that means too much to me to not do. So having an opportunity, I'm very grateful to do. But when I started, I went through months and months of different trainings on mental health and that sort of thing to help prepare me to do this.
So I worked in schools for lots of years. Not sure I can get through this. The thing that you have talked about that was difficult, and I worked with kids that had emotional and behavioral problems for lots of those, and had several students that we knew were at risk that committed suicide. They came from terrible home situations. The thing that, and I've done the trainings that you've talked about, are similar ones, you know. The thing that was hard was, how do you not talk about suicide and set up a situation where kids do copycat suicides and still honor that kid that died?
Yes.
And I watched kids struggle with that Tom died and nobody's talking about missing him and
Yes.
how special he was.
So my postvention training, this is something we did a really deep dive into, is the memorials, right? With suicides, one of the most difficult things for especially schools to understand is we don't want a memorial, okay? If we put something in the yearbook, if we dedicate a park bench to them, this is now a way for other kids to say, I can be remembered if I do this, right? And that's kind of the flip side that people don't really think about, right? So how do we still honor this kid without increasing the risk in the others? And it is a lot more of promoting mental health rather than promoting the death. We celebrate those that are alive now instead of the death, right? And that doesn't mean we can't do anything, but we curb it a little. If the team wants to wear jerseys with the deceased name on their back, how about instead we put the 988 number on there, right? It's not about the person that died, it's now about how to get help. All right, so it's still okay to do things as long as we can curve it more towards that help behavior rather than focusing on the death. And then anyone that is suffering, they can now see this and say, okay, I should reach out to.
So you would teach that doing a walk run every year with the idea of raising money to help with suicide prevention is okay or not okay? I've watched the families for 20 years really struggle with some of this stuff, like how do we remember our son or our brother in a way that is okay, that doesn't lead to things that are bad?
Yes, and the answer is yes and no to that one. So another thing I talk about in schools, you never make a mandatory thing related to a suicide death, right? If a group of kids still wants to get together and do something, you direct them to the family to do that thing, right? It shouldn't be up to the school to do it, because then it is increasing that risk factor again as well. It is okay for people to be remembered. It's okay for us to talk about those we lost through suicide. We do have to be mindful of the other people around, but if people do want to get together and do something, that's perfectly okay. But it should not mean everyone else should go do it. And it's usually something we don't promote at the school if there's like especially a name tied behind it, because then that is another "that's how I get remembered" moment. And that's when I talked about writing policies in postvention. That is a lot of what we focus on, is how to handle death overall, because all deaths need to be treated the same, within mind that if a suicide happens, we have to make sure that's available too, right? Because if you have a dedicated page in the yearbook or a plaque for every student that died in the school, and you know you're not supposed to do it for one that died by suicide, there's not going to be outrage if you don't do it for that student. Even though it's the correct way, the most up-to-date way to do things, people don't understand. So I do go in and we talk through policies in general about death and those sort of things, just to help overall for future events.
So how long have you been doing this?
I've been here a little over 2 years doing trainings.
Wow. How many hours have you? Sounds like another project, another.
I did the math. So September, my busiest month, what I ended up with 18, 19 trainings that month, which doesn't sound like a ton, but I travel for most of them, and my farthest one was 3 hours from my office. So those become full day ones, and I mean with weekends and stuff, I'm only 20 hours in. But one thing I do want to point out, I will go to night shifts. I've gone to hospitals and hit night staff nurses. I do weekends, that sort of thing. If I'm available and you want a training, I will do it for you. Okay, I will work around schedules, whatever I need to. Just make sure I get to see my 2 kids every now and then. That's all I need.
Please.
Yeah,
For their mental health.
exactly.
Yeah.
And mine.
You know, I will say that I know about 5 people in this community, including myself, that are trained in, now I just lost it, mental health first aid. And some of those trainings are happening in this community, and I know that's not on your list, so maybe that's why we're missing you
So,
not coming here, but.
That is one provided by the region. It's just, it wasn't me.
Okay.
We have prevention overall. That one just falls under overall prevention. I specifically in suicide, it does cover suicide in there, but that's under Cheyenne Adams. Is her name.
Okay, so I will just say that there's some of those trainings that are happening, so the word is,
Good.
but also, Hunter, I know, I think you're connected with the Lost Team?
Yes, I did
So,
mention that.
yeah.
That's correct. So the Central Nebraska Loss Team is the one that will most likely be the one to come to Hastings if there was ever a suicide loss. They meet with close family and friends of individuals that died. And what's going to happen, you're going to get 2 lost survivors that have lost someone themselves and a trained therapist to come with. And they meet with and they walk you through like, hey, here's what we can do. They have support groups and they kind of let you know the process and help you through everything. So if you ever need contact with the lost group, if there ever is a suicide, and especially if there's someone close to them struggling, let me know and I can get that lost team mobilized too.
Does that happen in all the regions? Is that
So
available in
the
all-
lost team is something separate from the regions.
Okay.
I wouldn't be considered a lost survivor just because I didn't lose anyone like immediate family wise. So I am on the lost team as a supportive role basically only. I can't respond to calls, that sort of thing. And it's going to depend on the area you live in. I believe our lost team they travel about an hour, hour and a half max, just because, I mean, they have jobs and stuff as well. It would be up to the area you're in. I'm not sure.
Okay.
I know some of them have disbanded, some of them have started up again, so I'm not 100% sure. But I can find out in a region if you ever need to.
Okay, great. Any other questions? Thank you, Hunter, that was
Yeah.
a lot of information.
Thank you, sorry, I
Very
threw
useful.
that at
That's very useful.
you. And then please help yourself with some information, goodies, whatever you need up there.
Okay, I'd like to announce the upcoming programs, or did you have that?
I've got it here.
Okay, go ahead.
December 13th, Marty Staney, Director of Environmental Services for Hastings Utilities, will present information on the water quality in Hastings. January 10th, ESU 9 building, Drew Harris, the ESU 9 director, is gonna, him and others are gonna present information on mental health and education. That's all we have right now, right?
Just so you know that December 9th, or December 13th is here, and
Right.
January 10th is at the ESU 9 north of
Yep.
town for the
And
education.
I'll email out a reminder on those. All right,
Sign in.
yeah, and please sign in and keep Judy's records straight.
I didn't read it.